Thank you to the audience for coming out in such large numbers. For those of you that are entering the room and looking for a seat, there's lots of seats in front. And we promise not to ask any questions of the people in front, only those in the back rows. So anyways, you've been advised. Claire has given a brief overview of what it is that we're going to be looking at today. And if we could just jump to the next slide, please. I'm having trouble with the slide control. It's this one. Sorry. So these are my disclosures. I've worked with a number of different people, and I'm participating in clinical trials that are currently being done on monoclonal antibodies for the treatment of nasal polyposis, which is a very exciting moment. So what is the burden for disease, and how frequent is this? Well, we're starting to have epidemiological data. It's not perfect yet, but we're certainly better than we were 15 years ago. And currently what we're seeing is that we have patients that are present. North America, we have a preponderance. We seem to have an incidence that skews between 4 and 6, depending how it is, with reports from Europe and Brazil and China, all coming in with reports that are at least 4 or 5%. Some patient questionnaires are a little less sensitive, and nasal endoscopies suggest different instances of the disease, again up to 4%. So we see that this is a frequent problem, so that as otolaryngologists, we'll frequently be solicited. Now we're starting to understand what the typical patient looks like. Understand that the refractory patient is the one that takes up a lot of our time and interest. But again, as I mentioned this morning, we're hoping to take back information learned from racing or from treating difficult patients to extrapolate to these findings. And we know that the common patient is a middle-aged male, but that when it's female, they have a less benign evolution of the disease. And at least in the United States, what they found is patients with nasal polyps had comorbid asthma, aspirin-exacerbated respiratory disease, and that had often been treated with serious medications. This is preaching to the choir in this room, but we expect this. And in the European data, again, that we see that there is an association with the male gender, probably due to the group size, and again, the association with that asthma. So a question about a gender-based predisposition that we're just beginning to explore, and a strong link with asthma, which has been a point of fascination for the past 15 or 20 years since I've been in the field, and that's led to a lot of science. And as we talk about type 2 disease, we understand that asthma and chronic sinusitis, asthma and allergic rhinitis, type 2 diseases. These are diseases that involve eosinophils in the type Th2 inflammation system. However, we also realize that atopic dermatitis as a barrier disorder with bacterial dysbiosis and continued inflammation with eosinophilic infiltrate is also a Th2 type disorder. So we're beginning to appreciate that the patients have a common pattern to their presentation. As we look at the individual quality of life of this disease presentation, that always takes into account, of course, you're miserable because you have asthma and nasal polyps, but when you look specifically at the disease-specific quality of life, you see that it gets worse. And patients with chronic sinusitis, whether it's chronic sinus without nasal polyposis or with nasal polyposis, have a worse overall quality of life than do the controls. However, the males do slightly better, but the females do worse. So this is something we're really going to have to continue with. And to talk to something Claire brought up, this is the sense of smell. And in the blue line here, we see the anosmia. And we see that anosmia is present in almost half of all patients with chronic sinusitis with nasal polyposis, which makes it a distinguishing feature of the disease with chronic sinusitis without polyposis, and also which gives us a therapeutic target, an outcome we'd like to achieve that we've simply never been able to manage completely, preoperatively or prospectively with our medical therapies. So currently, how are we treating patients? Well, fortunately, the guidelines which do exist tend to agree. Unfortunately, they agree by limiting themselves to the statements which can be evidence-based or tentatively evidence expert agreed, and that we come up with the same recommendations. Essentially, it's a stepwise approach, which is a process of trial and error. We begin with intranasal corticosteroids in different forms to improve application. We will use oral steroids to manage exacerbations or to try to manage the disease initially, and use surgery when these fail. when these fail, I'm sorry. How severe the patient is will influence the course of management. Someone who may present initially with severe nasal polyposis may be managed with oral steroids, then topical steroids, for example. And that surgery, when nothing else works, we go to surgery. All of these have limitations, and one of the problems with surgery is, well, what do you do after surgery? There is pharmacologic therapy. I think that when we speak about cortisone, we move to what is almost the gold standard, which has advantages and disadvantages. And we see here in this very nice work from Philippe Gavart working with Klaus Backert, is that we see that a single course of oral steroids initially gives a rapid decrease in nasal polyp scores and in symptoms very rapidly following administration of medication, but that it comes back very rapidly. And that when we combine this with the risks associated with corticosteroid therapy, this becomes something that we don't want to use as our general go-to. We can't continue patients on these. And just to remind you, the risks are real. Hip fracture, vertebral fracture, the cataract, psychiatric episodes, while we don't tend to consider that topical steroid use has the risks, oral steroid use does have the risks, and some of these things, notably the fractures, carry a risk of fatality. So that we're not balancing nothing versus surgery. We're balancing surgery versus another medical intervention, so we need to think about that. This is a slide taken from Heinz Stamberger's original diagram that's been difficult to improve on, and the goals is to remove the diseased ethmoid sinus mucosa and tissue and the bony partitions in given area for ventilation to have, of course, all of my patients look like this. Not really, I'd like them to look like that, but when you have a sinus that's open, it's ventilating, and you can reach it with an irrigation therapy. Now, I wish it was perfect, it isn't. And we see that one of the problems with surgery is that disease recurs, and that this tends to recur by an early time point and then persist following that. So the patient who goes bad early tends to persist bad, and you will see these changes early. And we see that in this group taken from very expert surgeons, at least 40% of the patients had a recurrence seen endoscopically within 6 months. So it shows that we really need to up and manage our medical management, because as we think of our patients with nasal polyposis, we should think beyond the nose, think to the respiratory tract, and think beyond there. Because what we're trying to manage is not just the regular disease, we're looking to manage people all the way through. And in these patients where disease has failed them, the patients that are refractory to surgery, we need to consider that all this is unfortunately coming back and impacting their comorbidities. So as we manage these patients with severe disease, if we have success in the sinuses, we hope also to have a successful impact on other disorders such as their asthmatic component. I'll leave time for the other speakers. Thank you very much. Oh, there's conclusions. So, I'm sorry for that. It's been a long morning. But it's just the take-home messages before I hand it over to the other speakers is that CRS is a frequent condition, and that the symptoms that they have really do make the patients miserable. And as we become more attuned to sense of smell, we'll realize how unhappy specifically patients are with the loss of sense of smell. We're just learning that. For the moment, the current paradigm is steroid surgery with different beliefs within, but this refractory status, as you've seen in this meeting, is a real concern to us all. And that we need to up our game and modify our current treatment paradigms in order to better address everything that we have and try to even control those outliers that are currently reaching out of our grasp. So with that, to tell us how to do it, I'll leave that to our next two speakers. Thank you very much.